Good morning. I would like to thank AIOS and Dr. Karan for giving me this opportunity. I will be talking about glaucoma management post-penetrating keratoplasty. So we know that post-PK glaucoma is a cause of irreversible visual loss and graft failure when our endothelial cell count is already low. There are difficulties in getting accurate tonometry readings, and the presence of media opacification makes the assessment of optic nerve and visual field further difficult. So if we have a smooth and regular graft surface, then Goldman applanation tonometry remains the gold standard. But this is not the case very often. So whenever we have irregular corneal surfaces, modalities like tonopin, dynamic contour tonometry, or rebound tonometry can help us get accurate IOP readings. It is just to emphasize here that corneas which have epithelial or stromal edema tend to give us inaccurately low intraocular pressure readings. A very nice review article by Dr. Tanuj Tada and his team. So talking about the mechanisms of this raised IOP after PK, there can be open angle or angle closure glaucoma. So in open angle, we have early onset and late onset cases. So early onset can be because of retained viscoelastic or hyphema, vitreous in anterior chamber. Late onset cases can be, the patient might be a pre-existing case of POAG, and steroid-induced glaucoma is a very common cause. In angle closure cases, pre-existing PAS, wound leak with further shallowing of anterior chamber can be the causes for early onset glaucoma. Pupillary block and malignant glaucoma can cause early onset or late onset rise in IOP. So progressive synechial angle closure after penetrating keratoplasty remains the main cause for angle closure glaucoma. So whenever the media permits, a gonioscopy is a must. A 55-year-old gentleman underwent therapeutic keratoplasty for corneal abscess here. We can see that the surgeon had to take a large graft. So this case somehow had higher IOP readings after the post-operative follow-ups. And the anterior segment OCT here shows that there is peripheral anterior synechy. So such kind of a picture is very common when PK is performed after suppurative keratitis or corneal perforations. The surgeon has to perform large trephination. So in that attempt, very often there is TM collapse, which makes the functioning of TM even bad. So for diagnosis of such cases, other than getting IOP readings and gonioscopy, we try to do the optic nerve evaluation after dilatation and take sequential disc photographs on follow-ups. In cases where we have a failed graft and the media is already hazy, UBM is really very helpful. It helps us to assess the angle and the extent of iridocorneal adhesions. Like we can see there is PAS in the image here. Talking about the management, prevention is better than cure. So intraoperatively, we can take care of certain factors like using an oversized donor button, performing synequializers if we know that this patient already has pre-existing PAS, a thorough viscoelastic removal at the end of the surgery if it is used while performing PK, and a careful wound closure so that we do not come across further wound leak and AC shallowing. So this patient was taken up for cataract surgery months after therapeutic keratoplasty. We can see a gentle release of posterior synechy is being done here under high molecular weight OVD. And she also had PAS. So before proceeding for cataract removal, gentle sweeping of peripheral iris was done. And this patient did well in terms of IOP after this surgery. Post-operatively, judicious use of topical steroids helps us to control inflammation, prevent PAS formation. But yes, IOP monitoring is a must, keeping the possibility of steroid response in mind. Cycloplegics help us to keep the pupil mobile and reduce the chances of pupillary block glaucoma. Medical management remains the first line of treatment after PK as well. I am just highlighting the relevant side effects here. We know that beta blockers and alpha agonists are known to cause superficial punctate keratopathy. Carbonic anhydrase inhibitors can be used for short-term therapy in grafts, in good grafts which have a good endothelial reserve. But yes, on long-term therapy, they suppress the carbonic anhydrase enzyme in corneal endothelium and cause graft failure. Myotics are not recommended as they break the blood aqueous barrier and can cause graft rejection. They increase the chances of retinal detachment in aphakic eyes. On encountering steroid response, reducing the dose of steroid to the minimum required one, or switching on to low potency steroids, or substituting with cyclosporine really helps us bring down the steroid dose. In eyes which have clear grafts, open angles, and moderately elevated IOP and glaucoma medications, laser trabeculoplasty can be considered. If there is a component of pupillary block, laser iridotomy needs to be done. Conventional trabeculectomy has high risk of failure in the longer run because we know there are more chances of perilimbal scarring and fibrosis, especially in aphakic eyes. Glaucoma drainage devices have, they control glaucoma in a higher percentage of patients, like this case of mine who had uncontrolled IOP on maximum medication prior to the surgery, and after performing Ahmed glaucoma valve implantation, he did well in terms of IOP. But yes, the possibility of inflammation-induced graft rejection and tube graft touch, which can further reduce the endothelial cell count, has to be kept in mind. Lastly, in an attempt to reduce the aqueous production, cyclodestructive procedures can be considered, abiding by the time. Thank you.